Okay, I would like to thank the committee and the moderators for a chance to present. The title of our presentation is Roux-en-Y gastric bypass as a salvage procedure in complicated patients after failed fundoplication. Gastrointestinal reflux disease is the most common disease of the GI tract. While the majority of patients can be managed pharmaceutically with proton pump inhibitors, a subset of patients undergoes anti-reflux surgery or laparoscopic fundoplication. However, 2 to 30% of the time, anti-reflux surgery fails to control symptoms either initially or symptoms recur over time. Thus, 3 to 6% of patients will require revisional anti-reflux surgery. The most common operation at the time of second procedure is a repeat fundoplication, usually still a Nissen. Salvage Roux-en-Y gastric bypass, however, is used in a subset of patients instead of a reoperative fundoplication. The benefits of such procedure is that it ameliorates GERD by diverting the flow of acid and bile from the GE junction and avoids dysphagia from an outflow obstruction of a redo wrap, and can be beneficial if there is damage to the fundus or the GE junction at the time of reoperation. In addition, there's the added plus of weight loss for those who are morbidly obese. Our study sought to characterize the perioperative outcomes and overall effectiveness of a salvage Roux-en-Y gastric bypass and to compare and contrast this to a reoperative fundoplication cohort. It was a single institution, single surgeon, retrospective review conducted between the years of 2011 and 2017. The criteria for salvage Roux-en-Y gastric bypass in our study was 2 or more prior fundoplications, symptomatic post-surgical gastroparesis with documented delayed gastric emptying by nuclear medicine study preoperatively, the presence of morbid obesity defined as a BMI greater than 35. During our procedure, we created a roux limb of 100 centimeters, a BP limb of 25 centimeters, and a gastric pouch of 20 to 30 milliliters. For those with a BMI greater than 50, however, we extended the length of our roux limb and our BP limb to 150 and 50 centimeters respectively. Our intention at all surgeries was to create a gastrojejunostomy. However, intraoperatively, in 5 cases, it was technically necessary to perform an esophagojejunostomy. Of note, all 5 of these patients had 3 or more fundoplications. The GERD HRQL score is a quantitative measure of GERD symptoms from 0 to 50. It consists of 10 questions where the respondents are asked to respond on a Likert scale from 0 to 5, with 0 being no symptoms and 5 meaning the symptoms are incapacitating, and the patient is unable to go normal activities. Baseline demographics of our study are as follows. There was no difference in age or gender between the 2 groups, with the preponderance of patients being female. However, there was a difference in the preoperative BMI, presence of esophagitis, and gastroparesis between the gastric bypass and the redo fundoplication cohort, which is consistent with our selection criteria. There was no difference between Barrett's esophagus. And also consistent with our selection criteria, there was a higher number of prior fundoplications in the gastric bypass group. Preoperatively, our workup consisted of an upper GI, an EGD, and a gastric emptying study when clinically indicated. When stratified by the number of prior fundoplications, the incidence of preoperative esophagitis and gastroparesis increased with each prior procedure. Also, of note, there was no difference in Barrett's esophagus. Perioperatively, these are outcomes. As expected, the operative time is longer for those undergoing gastric bypass. In addition, the length of stay, the rate of readmission and reoperation, and the presence of a grade 3 or higher Clavey-Dindo complication was higher in the gastric bypass cohort. However, when our 5 patients that required an esophagojejunostomy are excluded, the rate of readmission, reoperative intervention, and high postoperative complication is no longer different between the 2 groups. When looking at our outcome data, or the GERD HRQL score, both groups improved, and to a similar degree, from baseline to 2 years. There was a slight difference at 1 year, however, this difference disappeared at longer-term follow-up. Patient satisfaction was similar at each measured postoperative interval between the gastric bypass and the redo fundoplication group, and overall was pretty high, ranging in the 70s to 80%. The limitations of our study are as follows. It is a retrospective review of prospectively maintained data. It was a single surgeon who performed all cases, and our loss to follow-up may impact our results with regards to symptomatic outcomes. Conclusions of our study. Salvage Roux-en-Y gastric bypass provides good outcomes and acceptable morbidity in a complex patient cohort who underwent anti-reflux surgery but symptomatically failed. It is our opinion that it should be considered in those who are morbidly obese, who have had multiple prior fundoplications, or who have significant preoperative gastroparesis, severe esophagitis, or dysphagia. In addition, the number of prior fundoplications is correlated with the presence of this esophagitis, gastroparesis, and as we found, the need for esophagojejunostomy if Roux-en-Y gastric bypass is the chosen procedure. And finally, the salvage Roux-en-Y gastric bypass and redo fundoplication are both result in a significant reduction in the GERD AtriCurl score and a very high level of patient satisfaction. And as our data shows, esophagojejunostomy is associated with increased morbidity, more prior fundoplications, and thus is a more complex case.